Good evening, everybody. Can everybody hear me? Okay. This is Subramanian from Chennai. Okay, and the topic of my discussion would be chest X-ray in congenital heart disease. I'll start off with some basics. Maybe the first 10-15 slides will be very basic. Most of it you may be already aware, but it doesn't do any harm in going over the simple things so that we are very clear on that. And the later part of the talk, I shall be putting up some X-rays and I'll ask you to give your opinion and discuss those. Okay, chest X-ray is one of the most useful tests in congenital heart disease. And of course, a lot of importance is given to the contour of the heart. The contour has very distinct diagnostic importance, and the contour is also dependent upon the position of the chest during the X-ray, and therefore it can give you misleading information as well. One of the most important things for the chest X-ray is to be absolutely centered, and all of you know that if X-ray is centered, when the clavicles, the medial end of the two clavicles are exactly equidistant from the midline. So you do not see more distance on one side. So for example, this X-ray, the patient is turned more towards the right, and therefore you see a bigger gap between the left clavicle and the manubrium and less here. Similarly, and you see that the heart shadow tends to give you an impression as if the RV outflow tract, the pulmonary artery and the aortic knuckle are more prominent than usual. It may also give you an idea as if that the heart size is bigger. On the other hand, the same person, if he twists slightly towards the right and therefore a badly centered X-ray, you will find that the left cardiac border becomes less prominent and the right cardiac border becomes more prominent. Therefore, a badly centered X-ray is a source of great confusion, and that's one of the first things that you look at it in a chest X-ray. When you have a properly positioned X-ray, we know what structures form which part of the cardiac cylinder. As for example, as you come down from on the right side, the first part of it is a superior vena cava, and then a small bit of it in a curved fashion is formed by the ascending aorta, and after this concavity, the entire thing is formed by the right atrium up to the diaphragm. Therefore, right atrium, ascending aorta, and superior vena cava. On the left-hand side, to come from top to bottom, just below the clavicle, you find the aortic knuckle. That's the top of the descending aorta or the end of the aortic arch of aortic knuckle. And then as you come down, you can trace the aortic knuckle into the descending aorta. It gradually merges into the spine by an oblique line. This is a very useful sign to tell you that the descending aorta is on the left side and therefore probably a left aortic arch. Of course, there are other signs of the left aortic arch as indentation of the trachea, but this is probably a much easier sign. Just below the aorta would come the main pulmonary artery, would be the denser shadow inside, and the lighter shadow outside would be the left pulmonary artery. The left pulmonary artery is actually behind the main pulmonary artery, and therefore often less dense than the main pulmonary artery. Below the main pulmonary artery bulge, you often have a small concavity. That concavity is the place where the left atrial appendage in the normal situation lies, and if it is not distended, that area forms a small concavity. And then you can have another small bulge, often due to the right ventricular outflow tract, but most of the left lower cardiac border is formed by the left ventricular apex. It's interesting to see that the right ventricle does not appear any of the borders in the normal heart. Okay. Now, what I have drawn here is the size of the heart in relation to the chest. And you have heard of posterior and anteroposterior X-ray. You have heard of supine and the vertical position X-ray. And this figure tends to tell you why it's important. The same X-ray is taken in different positions will give you different impressions of heart size. You can see a best view of the heart size is obtained in the posterior view, and I will exactly define what posterior and anteroposterior is. You can see that the heart size shown by the red dashed line. When you take an anteroposterior X-ray, the heart size appears to be much bigger than with what it is. The same dotted line drawn here is shows how big the heart has become magnified in an anteroposterior view. In the erect position, the heart is more vertical, the diaphragm is sagged down, and heart size is often less. But if you take a supine X-ray, as often is done in the ICU setting, you find that the heart size flattens out, and therefore the estimated heart size will be bigger. You must keep in mind all these factors when you talk of abnormality, because increased cardiothoracic ratio is one of the most important physical signs and X-ray type in congenital heart disease. So why does this change in the size occurs in posterior, anterior, and anteroposterior views? All of you are familiar with X-rays, which ideally should be parallel. When the entire X-ray beam is parallel, the total bundle of X-rays which emanate from the source go through the object and fall on the X-ray film. The X-ray film is shown in brown. The object, that's the patient, is shown in blue here, and the X-ray source is shown as red. Now, the beam was perfectly parallel. You get exactly the same size image as the object. But in truth, the beam is never parallel. The beam is nearly parallel when it's close to the source, but as it goes away from the source, the beam diverges, as shown here. The beam diverges, and the amount of divergence keeps increasing as the distance increases. Therefore, what you get on the X-ray plate is a bigger image than the object itself. Can you see that? Now, the farther away the X-ray plate is from this object, the more will be the magnification. Now, for example, it's shown here, right? So when an object is far away from the source and very close to the X-ray plate, the amount of magnification due to the diverging X-rays is minimal. You see that here? On the other hand, if the object is closer to the source and far away from the X-ray plate, you find that the X-rays have a lot more distance to travel, therefore they diverge more and the object will cast a much larger shadow on the X-ray plate. Right? Therefore, the principle is to have the source as far as possible. The ideal X-ray would be infinite distance, but in practice we keep it at a distance of 6 feet. You must have seen in X-ray department, almost always the X-ray tube is kept about 6 feet away. But that's not always possible in the ICU setting. So this shows what happens here. Now, this is an ideal X-ray that we do in the X-ray room. Patient is erect, therefore the heart size is reduced. The patient faces the X-ray plate and the source is kept behind him. It's kept at a distance of 6 feet, or 6 to 10 feet. The X-ray beam is parallel. As it enters the body, even if there is some divergence, the distance between the heart and the X-ray film is minimal. So the magnification is very minimal in the posterior anterior X-ray. On the other hand, in an anteroposterior X-ray, the heart is closer to the source, away from the X-ray plate. Therefore, you have a larger distance for the X-rays to diverge, and therefore you have more magnification. The ideal X-ray would be posterior X-ray, but in case of children, they will be very scared to face the X-ray plate. In case of ICU setting where the patient is supine and bed, you are forced to take an anteroposterior supine X-ray, and therefore you have to make allowance in your reporting for the X-ray magnification. Situs is one of the most important features that you describe in a chest X-ray, and it's so easy to describe where the stomach bubble and the liver shadow is. Sometimes the liver shadow and the stomach bubble are not clear, or sometimes they may be ambiguous when you have a midline liver or when you have gas shadows on both sides. The absolute standard for situs is the closest absolute standard for situs is said to be the bronchus. And you have a morphological right bronchus, which is shorter on the right side, and a morphological left bronchus, which is supposed to be longer. So this can be identified only in a penetrated chest X-ray, as shown here. Therefore, when you are not sure of situs, ask for a high kV penetrated X-ray. where you can see the spine through and through, and you can also make out the trachea and bronchia. Now, how do you define the length of a bronchus? The length of the bronchus is from the point of bifurcation, you can see the carina here, from the point of bifurcation to the point where the first branch of the bronchus takes off. And usually the upper lobe branch, almost always the upper lobe branch is the first one. You can see in the penetrative X-ray very clearly where the upper lobe branch takes off on the right side and where the upper lobe branch takes off on the left side. It is the same X-ray, little magnified view. You can see that the right bronchus is more horizontal. It is shorter. The distance from the upper lobe bronchus to the carina is much shorter as compared to the left bronchus, which is longer. You can see the upper lobe branch taking off from here. Therefore, you know that the morphological bronchus on the right side is indeed the right bronchus, and the bronchus on the left side is indeed the morphological left bronchus. Therefore, it says it is situs solitus. You can have a ratio of the length of the right bronchus to left bronchus, and you know that the ratio would change in the situs inversus. In situs ambiguous, you probably will have a ratio close to 1 because both the bronchi are either right bronchi or both are left bronchi. Okay? Now, all of you know how cardiothoracic ratio is measured. It's the maximum dimension of the cardiac contour, not shown by a single line as shown here. You must take the maximum dimension of the right border and the maximum dimension of the left border and measure it to the maximum inner diameter of the chest, probably at the lower part of the chest here, and express as a percentage. Now, occasionally you do find cardiomegaly cannot be explained by the physical finding. Be careful that there are no other contributory factors. If you look at this X-ray very carefully, there is a slight scoliosis of the spine. Now, chest deformities are one of the most important causes of altered CTR, and if you are not careful, you may be mistakenly diagnosing cardiomegaly. If you look carefully at this lateral X-ray, now this same person, when you found mild scoliosis, we ordered for a lateral X-ray, and you find there's a marked chest deformity of the front of the chest. The chest is actually a pectus excavatum. You can see the sternum going inside here, coming back, and therefore this would squash the heart sideways, and therefore the cardiothoracic ratio would appear larger than. Therefore, try to exclude all non-cardiac factors before you diagnose cardiomegaly. Because once you diagnose cardiomegaly, you're making a diagnosis of organic heart disease. And therefore, you should be sure that cardiomegaly is indeed present. This shows how a cardiothoracic ratio should actually be measured. The maximum dimension to the midline, from the midline to the maximum right cardiac border, and from the midline to the maximum distance of the left cardiac border, and divided by the maximum inner diameter of the chest, wherever it is. Generally, it's in the lower chest. Although the contour in the frontal X-ray or post-anterior X-ray is useful, occasionally you do need to go to the lateral X-ray to diagnose chamber hypertrophy. This shows a normal chest X-ray in a lateral position. Please note that the right ventricle doesn't appear in the borders in any of the any frontal X-ray. But a lateral view is useful to diagnose right ventricular hypertrophy because in the normal heart there is a clear retrocardiac space, and the normal right ventricle appears as the contour in the anterior part of the cardiac fillet here. You see, it's separated from the sternum by a very clear space. This retrosternal space gets filled up whenever the right ventricle is enlarged. And therefore, a lateral X-ray is one of the easy ways of diagnosing right ventricular hypertrophy. You can use it to diagnose left ventricular hypertrophy also. Please note that the posterior border of the heart and the lower part is formed by the left ventricle, and the upper part is formed by the left atrium. Now, normally, all of it stays in front of the esophagus. It doesn't indent the esophagus more than a minimal degree, and definitely doesn't extend onto the spine. So this would be a normal left atrium, normal left ventricle, and a normal right ventricle. I'll show you later how a lateral X-ray can help us diagnose cardiomegaly. For example, here, look at the post-anterior X-ray, the CTR ratio would probably be borderline, just crossing 60%, and it does appear to be a good inspiratory X-ray. If you count the number of ribs, the diaphragm seems to be 1, 2, 3, 4, 5, 6, 7, 8. The ideal inspiratory film, the diaphragm should be somewhere around 8 to 10 ribs, counting the posterior end of the rib, and therefore this X-ray can be interpreted for cardiothoracic ratio. If you notice that the left ventricular apex is dipping down into the diaphragm, apex is pointing down into the diaphragm, and this is what we call a left ventricular contour. So there's some increase in cardiothoracic size, and it appears to be a LV configuration. This, however, does not prove it is left ventricular enlargement. You suspect it is left ventricular enlargement. A lot depends upon correlating it with your physical findings. If you want to be sure of left ventricular enlargement, you could take a lateral chest X-ray, and you now find that the lower part of the left cardiac border is extending well beyond the normal extent, and in fact it's overlapping on the spine. If you remember the previous lateral X-ray, it was clear of the spine. See that the left ventricle extends backwards and is overlapping the spine. And this is one definite evidence of left ventricular hypertrophy. The upper part of the posterior border is formed with the left atrium. So you could use that for left atrial enlargement. See, however, that the retrocardiac space is not filled up. Therefore, this patient probably has left ventricular enlargement, but does not have any significant right ventricular enlargement. Here we have a patient where the cardiothoracic ratio still appears to be normal. That is probably less than 60%. Therefore, it's difficult to diagnose any chamber hypertrophy. However, the contour is abnormal. See, the apex seems to be somewhat rounded, and something is making the apex sit up. It's pulled up from the diaphragm, and it's separated from the diaphragm. So something is holding the left ventricular apex up, and generally that's attributed to the right ventricle. This is called a right ventricular type of apex. However, this is not conclusively proof of right ventricle. If you want to be more certain in a plain X-ray, take the lateral view. You see that the more of the heart is apposed through the sternum, that right retroexternal space between the heart and the sternum has got obliterated. And this is one clear evidence of right ventricular enlargement. You see, in this case, the left ventricle is not enlarged. It's not overlapping the spine. Neither is the left atrium enlarged. But the right ventricle seems to be opposing the sternum, obliterating the retrocardiac space, retrosternal space. Therefore, this is one evidence of right ventricular enlargement on a plain chest X-ray. Atrial enlargement, I think all of you are familiar because it's more commonly described in valvular heart disease. The right atrium forms the right cardiac border, and there are many criteria for diagnosis of right atrial enlargement. In an adult or grown-up child, the enlargement of right atrium is diagnosed if it extends more than 3 interspaces in the vertical direction, or it extends more than 5 centimeters from the midline. Now, you can see that the right atrial border forms a single density. There is no double density here. You suspect there may be left atrial enlargement when you have a double density. You can see one density here. Can you see that? The one density here, and there is another density outside. The outer density extends up to the diaphragm, and therefore this has to be the right atrium. And what is behind and inside must be the left atrium. Now, the left atrium can enlarge in more than one direction. It can enlarge towards the right side, and therefore it will cause a double density here. It can enlarge on the left side, where it appears in the angle between the pulmonary artery and the lower part of the cardiac cylinder. Now, this bulge here is the concavity is getting filled up by the enlargement of the left atrial appendage, and in more severe cases of mitral regurgitation, the left atrial appendage will probably mark the more marked bulge. It can also expand in the vertical direction. It's difficult to make it out in the inferior border, but in the upper part of the left atrium, the carina outlines the left atrium. Can you see the carina here? Left bronchus, the carina, and the left bronchus. Therefore, this angle of carina is normally 70 degrees or less. Sorry. Now you can see that the angle of the carina here is opened up to form almost a 90 degrees angle, and the left bronchus, instead of going down more vertically, is almost horizontal. Now, so you have all three signs of left atrial enlargement here in the frontal X-ray, a double density here, a bulging left atrial appendage, and elevated horizontal left bronchus with widening of the carina. In the lateral X-ray, you see the upper part of the posterior border bulging onto the spine. You can see it on a plain lateral X-ray, but if you do a barium swallow, you see a marked indentation in the barium swallow. Of course, with the advent of echocardiography, nowadays we do not do lateral and barium swallow routinely, but there is something which you should be aware of. The next most important thing is the pulmonary vasculature. Now, it's important to notice that when you are a general pediatrician or physician, you can talk of increased pulmonary vasculature. There's no such thing as increased pulmonary vasculature. We talk of only three terms when it comes to cardiology. One is pulmonary venous hypertension. The other is pulmonary arterial hypertension. And third is increased pulmonary blood flow or pulmonary plethora. Now, the word vasculature increases everything. The flow, that is, whether plethora is present or there is oligoemia. Pulmonary venous hypertension present or not. And pulmonary arterial hypertension present or not. All three are included in pulmonary vasculature. So please never say pulmonary vasculature is increased. You're inviting trouble. Now, you must know what is normal. Normally, the vessels in the lower half of the lung are always more prominent than the upper. Now, which vessels are usually seen? Usually you see only the arteries. Therefore, the lower lobe arteries, because of gravity, have more flow, they get more blood than the upper lobe, and you see that the vessels in the lower lobe are always more prominent. Okay. Secondly, the vessels are always larger at the hilum, and as they go towards the periphery, they become thinner and thinner. In the normal lung, you see vessels in the middle proximal one-third, and in the middle one-third. You may not see any vessels in the peripheral one-third. Therefore, you have gradual tapering of vessels from central to periphery. In the lateral one-third, you may or may not see any vessels. And finally, in the adults, the normal right pulmonary artery size is said to be less than 15 millimeters. In children, less than 10 millimeters. So these are some normal values which are useful to diagnose the abnormalities of veins and arteries in pathological conditions. Now, there are certain terms used. Normally, the lower lobe vessels are more prominent than the upper lobe vessels. Some people give it as a ratio of 5:1. That is, you see 5 lower lobe vessels, you can see 1 upper lobe vessel. Some people use the word catheterization. That is, when upper lobe vessels become more prominent than the lower. I'll show you some examples of this later on. Now, when catheterization occurs, typically that happens in pulmonary venous hypertension. The most classical example is mitral stenosis. However, any condition with increased pulmonary venous pressure, such as mitral valve disease, left ventricular disease, catheterization. In plethora, on the other hand, when the pulmonary blood flow increase, also the upper lobe vessels become more prominent. But here, what you call equalization. Upper and lower lobe vessels actually look equal. Normally, the central vessels are bigger than the peripheral vessels. But when this centralization becomes exaggerated, that is, the central vessels are huge, but the periphery vessels are far more thinner than normal, we call what is called centralization, and that happens typically in pulmonary arterial hypertension. Lateralization, one side blood vessels look more than another side blood vessels, can occur in more than, that is, unilateral increase or decrease in blood flow, can typically occur in pulmonary embolic obstruction, or in congenital heart disease. More commonly it is due to one pulmonary artery being stenosed or obstructed. You could have localized abnormalities, typically occurs in a case of pulmonary AV fistula, and typically you can have that is multiple patterns like collateralization, where the pattern doesn't fit in any one of this catheterization or centralization, to where you have a diffuse reticular pattern and typically found in collateral supply from anterior. So you must be aware of these terms some people use to describe X-ray. Now this X-ray shows, let's describe it first and then we diagnose what it is. You can see that the blood vessels are equally prominent in the upper lobe and the lobe. That's what is called equalization. The blood vessels are large in the hyaline. If you measure it, being a child, it's definitely more than 1 centimeter. Therefore, the pulmonary are large in the central part. You can see that the vessels are large in the middle part of the hyaline. And you can also trace the vessels right until the periphery. You can see the vessels right in the periphery, and this is a magnified view. You can see the X-ray going right into the periphery of the lung. Therefore, this X-ray would mean increased pulmonary blood flow or plethora. Therefore, large vessels in the hyaline, large vessels in the middle third of the lung, and vessels being traced in the periphery of the lung indicates pulmonary plethora. Generally, this is accompanied by a larger size in the main pulmonary artery. Obviously, if more blood comes into the periphery, it has to come through the central pulmonary artery, but the main pulmonary artery is also big. When the arterioles are big, some of them would be running end on to your chest X-ray, and therefore these vessels would be seen as a rounded shadow. These are called end-on vessels. Now, end-on vessels are seen even in the normal X-rays, but these are considered abnormal if they are bigger than the accompanying airway. Can you see the accompanying airway here? And you can see that the accompanying vessel, this rounded shadow, is bigger than the air shadow. Okay, so this is an abnormal end-on vessel. Now, end-on vessels are considered abnormal if they are more than 5 cumulatively on together both sides, or they are more than 3 in one interface on one side. Can you see one end-on vessel, one end-on vessel, one end-on vessel? See multiple end-on vessels here, indicating along with other features indicating plethora. Therefore, it indicates a left to right shadow. Now, you could have end-on vessels only in the periphery, in one area of the lung, without enlargement of the central pulmonary arteries or the pulmonary arteries. In that case, you could diagnose pulmonary plethora in only one segment of the lung, typically as occurs in a collateral supplying one particular lobe. Therefore, you could have plethora if it's generalized, both ones. You could have plethora if it be one lung. You could have plethora affecting part of one lung. All of it indicates only increased pulmonary blood. Okay, so that's plethora. Now, what is pulmonary venous hypertension? Pulmonary venous hypertension, one of the most important findings, is cephalization. The upper lobe veins become very big compared to the lower lobe. Now, if you see this X-ray, you find that the upper lobe vessels are larger than the lower lobe vessels. The lower lobe vessels are very difficult to see on the left side because the cardiac is less massive. You have to go to the left side. Now, this is cephalization. Upper lobe vessels being more prominent than lower lobe vessels. A magnified X-ray, can you see this big vessels going into the upper lobe? These vessels are abnormal. They are bigger than the lower lobe. They look like a horn of a stag, a deer horn. This is a typical staghorn sign. You see that big upper lobe vein. Staghorn sign, very suggestive of pulmonary venous hypertension. So, this area is magnified to show that the upper lobe vessels here are much bigger than the lower lobe vessels. So, this is called cephalization, which is the earliest finding of pulmonary venous hypertension, also called as stage 1 of pulmonary venous hypertension. When pulmonary venous hypertension becomes a little more severe, fluid exudes out of the vessel into the interstitium, and they form interstitial lines. Can you see this horizontal line? Very well shown by this arrow here. You can also see smaller horizontal lines in the prostophrenic angle here. Now, these are lines of interstitial fluid in the lung alveoli, and they have been called as curly B line. You can see it on both sides in the lower lobe. So this is the stage of interstitial edema, that is a little more advanced stage of pulmonary venous hypertension. More curly lines. Here you can see long lines extending towards the hilum, and these are typically called as curly A lines. Okay, you have curly B lines at the periphery horizontal line, you have curly A lines extending towards the hilum. And of course, you could have curly C lines, which effectively mean fluffy shadows inside. When pulmonary edema fluid increases, The blood vessel outlines become indistinct, and that's the stage of pulmonary alveolar edema. Roughly, it corresponds to the pulmonary venous pressure. Normal pulmonary venous pressure less than 12. When the upper lobe veins are prominent with capitalization or the redistribution, we believe that the pulmonary capillary pressure must be around 12 to 19. When you have curly V lines, it must be in the range of 20 to 25. When you have fluffy shadows and alveolar edema, it must be 25 or above. Now, these are X-rays of pulmonary edema. Can you see the vessels are indistinct. The vessels outlines are lost. We have a higher and indistinct on both sides, and therefore this is the stage of stage C pulmonary venous hypertension or pulmonary edema. It is a milder degree, a little more advanced degree, and then you have a hazy ground glass appearance of the entire chest. This is the stage of frank alveolar pulmonary edema. Therefore, you have different stages of pulmonary. It's important to remember that whenever there is plethora, also the lung water increases. And therefore, even in the case of large left to right shunt, you could have hazy lungs. For example, in this X-ray, this is a case of pulmonary edema, pulmonary plethora. But even here, you can see that the pulmonary blood vessels are little distinct. Therefore, whenever a large pulmonary blood flow occurs, some exudation of fluid does occur into the alveoli, and therefore, a large plethora almost always causes a pulmonary edema. Therefore, don't be surprised in an infant if you have a very large plethoric lung, you may have a frank appearance of pulmonary edema. Therefore, these are not watertight compartments. A very plethoric lung can have some evidence of pulmonary edema. A very edematous lung could have some end-on vessels and appear to be like plethora. Therefore, there is always some overlap in the X-ray sign. Your interpretation must be based on your clinical finding and what you expect in that particular patient. Please correlate your clinical finding before you give an X-ray report. The site of the shunt you could get by some additional features. Now, this X-ray suggests large left to right shunt, a plethoric lung. You could also diagnose that the left atrium is enlarged, the bronchus is elevated and the left atrium is enlarged. Therefore, you could diagnose, and it's somewhat a left ventricular configuration. Therefore, it has to be either a post-tricuspid shunt such as a VSD or a patent ductus arteriosus. On the other hand, the aorta is not very dilated, and therefore, one would suspect that it could be a VSD where the aorta is not very dilated. On the other hand, look at this X-ray. You have a large left to right shunt, very large vessels, multiple end-on vessels. In fact, you can see very indistinct hazy vessels. Therefore, a very large plethoric lung, very large shunt lung. Along with that, some interstitial edema because it must be a child. Now, the pulmonary artery is big, but along with that, the aorta is also big. Can you see that the entire left upper cardiac border is big with a very plethoric lung? The same thing is found in another patient here, a very large plethora, must be a child with a very large aortopulmonary shunt. Pulmonary artery is big, aorta is also big, and a severe plethora, a very large size PDA or an AP window could contribute to such an X-ray. Therefore, a dilated aorta with PA and plethoric lung, think of a patent ductus arteriosus or any aortopulmonary shunt. Now, this is an unusual type of plethora. So, no doubt about plethora. There is a huge heart, the plethoric lung, big hilar artery, very, very large vessels, lot of end-on vessels, and there is suggestion of pulmonary edema, very plethoric lung in an infant. However, the main pulmonary artery is not enlarged. The main pulmonary artery is concave. How can that be? You have a very large pulmonary blood flow without enlargement of the pulmonary artery. The only possibility is that the pulmonary artery is not located in its normal location. Now, when you have such an X-ray with a very plethoric lung and the concave pulmonary artery segment, the main pulmonary artery segment, think of a condition where the pulmonary artery is abnormally located. Examples are transposition of great arteries. The transposition of great arteries, the pulmonary artery doesn't form the left cardiac bottom. It is displaced more medially and it lies within the cardiac fillet. Another condition could be a double outlet right ventricle. A double outlet ventricle, again, with a malposed great artery, Maybe the pulmonary artery doesn't form the left cardiac border. Therefore, you have plethoric lung with a very apparently non-prominent main pulmonary artery. So think of transposition, think of single ventricle, think of double outlet right ventricle. This is plethora, but the main pulmonary artery is not present in its normal location. Okay? Now, this is the chest X-ray which all of you must recognize the cell head. Obviously, there's an infant. The egg on side appears with a narrow vascular pedicle. You can see that all hearts are egg-shaped for that matter. But in an infant, when you have the egg-shaped heart and the main pulmonary artery not particularly prominent, along with a plethoric lung, increased pulmonary vasculature, this is useful to diagnose a transposition. A transposition typically causes cardiomegaly, typically causes the pulmonary artery to be non-prominent because it's placed inside the cardiac cylinder. And the pulmonary vasculature is often increased because the pulmonary blood flow is increased in an uncomplicated transposition. So when you have a egg on side appearance in an infant or a neonate, think of transposition. This sign is not very useful in an older child. Another classical diagnosis, cardiac cylinder. Again, please make sure your X-ray is central before you diagnose this sign. The superior mediastinum is very wide, and sitting on top of the cardiac cylinder, it forms a figure of 8 or snowman appearance. You have one part of the 8 here and the other part of the 8 here. Now, this is a typical snowman appearance suggestive of total anomalous pulmonary venous connection to the supracardiac region. It's draining towards the superior vena cava via the anomalous vein. Now, you must know the components of the snowman shadow. The right cardiac border is formed by the dilated right superior vena cava, and the right atrium is dilated because the large pulmonary blood flow comes in through the superior vena cava into the right atrium first. Therefore, a dilated superior vena cava and a dilated right atrium. The left cardiac border is formed by the ascending vertical vein. When you have a left-sided vertical vein, you have a convex shadow here, and the lower part is formed by the dilated right ventricle. You can see the routed apex lifted off from the diaphragm and enlarged right ventricle. Therefore, that's a classical appearance. And this is the angiogram in the follow-through phase of LEO phase, pulmonary venous phase. You can see the right pulmonary vein coming and the left pulmonary vein coming here to form a common venous chamber, and then a common vertical vein ascending up into the innominate vein draining into the right superior vena cava. Now you know how the upper half of the snowman is formed. You also know how the lower half of the snowman is formed. Mind you, this is not enough. You can have a snowman appearance in many other conditions. If you have a large superior mediastinal tumor, if you have a large thymus, if you have some other mass in the superior mediastinum, you could very well have the same appearance. Along with this sign, you must have cardiomegaly and plethora. A snowman appearance and cardiomegaly and plethora, all three put together tells you the diagnosis of supracardiac total anomalous pulmonary venous connection. If you have total anomalous pulmonary venous connection draining into the heart or into the inferior vena cava, you do not get a snowman appearance. Well, I guess I have talked a lot. Now let me see what you have picked up. I'm going to give you some time to answer these questions. Let's see what you have to pick out of this X-ray. Yes, who wants to answer that? levocardia and cardiomegaly. Yeah, something else. Look at the right cardiac quarter. That's the clue I'm giving it to you. How do I go back to my slide? Yeah. Now, can you hear me? Now, this is cardiomegaly. I agree. There is plethora. I agree. But this is very unusual that you have a very prominent right superior vena cava here. Okay. You do not have a typical snowman appearance here, but you have a very prominent right superior vena cava. So this is an unusual example of a total anomalous pulmonary venous connection, where a vertical vein is ascending on the right side. So why I'm showing this X-ray is that if you have supracardiac TAPVC of the classical variety, you get bulges on both sides. On the other hand, if you have a bulge only on the right side, things maybe anomalous veins are draining into the right superior vena cava, and the vertical vein is on the right side. So this is an unusual presentation of supracardiac TAPVC. Okay? Right. Now, yes, who wants to talk on this X-ray? Yes, anybody? Somebody says right aortic arch. No, that's not. Have a look at the X-ray that I'm showing now.
Yes.
To show you what I mean by peripheral pruning. So what you're seeing is a very, very dilated main pulmonary artery here. You can also see that the hilar artery is big, but once you go beyond the hilar artery, you see very few vessels. There's a marked disparity between the hilar and central artery and the periphery. The same thing is shown here. A very dilated main pulmonary artery, a very dilated right pulmonary artery, and a left pulmonary artery. These are different patients, of course. So huge annulus on main pulmonary artery. That's an example of pulmonary hypertension. Now, this is to show you the differences. In pulmonary plethora, you have prominent central artery, prominent hilar artery, prominent metal lobe, and traceable vessels in the periphery, and you have end-on vessels. Along with that, you may have cardiomegaly and often left atrial or right atrial enlargement. In pulmonary venous hypertension, you have cephalization. You have very prominent upper lobe vessels. You have interstitial edema in the form of curly B line, and you may have further interstitial edema and alveolar edema in the form of ground glass appearance or hazy vessels in the periphery. Now, when it comes to pulmonary arterial hypertension, you have very large central artery, large main pulmonary artery, large hilar artery. But immediate branches after that would become thinned out because the arterioles are occluded already and very little blood is able to get into the lung proper. Therefore, a marked disparity, and the periphery actually looks very dark because of thin vessels. This is an example of pulmonary hypertension. Therefore, pulmonary vasculature, there's no single term as pulmonary vasculature in cardiology. You have pulmonary plethora, you have pulmonary venous hypertension, and you have pulmonary arterial hypertension. Please remember that these are not watertight compartments. In a given patient, one phase gradually merges into the other. Therefore, in a given patient, I have shown you ideal X-rays, whereas in a given patient, you could have some features of pulmonary plethora and some features of pruning and pulmonary hypertension. You could have a patient who has severe pulmonary venous hypertension, along with that some features of pulmonary arterial hypertension. Therefore, in a real life, you always have a mixed picture due to a combination of findings. Okay, that's clear? Okay, so these are examples of severe pulmonary arterial hypertension. It could be idiopathic PAH, it could be Eisenmenger syndrome. But the very important thing is when Eisenmenger syndrome develops, the heart size comes back to normal because the amount of shunt disappears and the heart size is often either normal or only mildly increased. It again starts dilating at the phase of heart failure when the right atrium and the right ventricle dilate. What does this X-ray suggest to you? Yes, I want some answers quickly so that I can talk. Yes, please. Answers for that X-ray. Now, the most important feature that I see here is the left upper cardiac border seems to be unduly prominent, isn't it? Now, the things which come to your mind are main pulmonary artery is dilated, but this seems to be extending all the way up to the clavicle. The other possibility is that it could be a combination of main pulmonary artery and aorta. For example, you have aorta pulmonary shunt, the aorta is dilated here, and then you have a main pulmonary artery. But generally in those cases, you would always see a distinct contour. You will see an aortic contour, and then you will see a pulmonary artery contour. This seems to be one continuous shadow going up, going right up to the clavicle from the heart. In congenital heart, now before you diagnose anything wrong with this contour, please make sure that it's a well-centered X-ray and the clavicles are equidistant from the midline. Because a patient, if is turned towards the left and almost like a left anterior oblique, you would get a bulge in the left upper cardiac border like this. And the normal pulmonary artery could also look a little bulge. Now, if you have a well-centered X-ray as shown here and have a bulge like this, in congenital heart disease, you must think that the aorta may be forming the left upper cardiac border, what is called a L malformed aorta. And this silhouette is supposed to be typical of congenitally corrected transposition of great arteries. It's not diagnostic, but think of that condition also if your physical findings and other features are consistent with congenitally corrected transposition. Okay? But this X-ray in addition shows plethora. The hilar arteries are increased and there are some end-on vessels. Therefore, this could be a congenitally corrected transposition with increased pulmonary vasculature, ventricular defect. Okay? A lot of this diagnosis of congenitally corrected transposition is made by associated findings. And I'll show you some examples later on in my talk. Okay, who wants to interpret this X-ray? Now, when I want to go to your chat session, I need to go off the picture, I think. I'm not able to see the chat when I have the picture on. Okay, who wants to interpret this X-ray? Yes, anybody taking the challenge? It's a large X-ray covering the abdomen and the chest. Yes, let me make it easier for you. Obviously, there's a thoracoabdominal X-ray, situs solitus. The most obvious thing, there is a pacemaker in the abdomen. So, child had abdominal pacemaker, and the wire is going up and inserting into the heart. So, it's an epicardial pacemaker, turned in infancy possibly. So, when you think of this chest X-ray, this patient is obviously sick. You can see an oxygen tube connected to the patient. You can see the ECG monitors connected to the chest wall, and you can even see a chest drain here. So obviously the patient must be a sick patient in ICU. Now come to the cardiac silhouette. What do you see in the cardiac silhouette? You see some cardiomegaly, you see some right atrial enlargement, but the most important thing is if you see a very big convex left upper cardiac border. So the thing which comes to your mind is congenitally corrected transposition again. It's exactly what I told you. And you know that one of the most common associations of congenitally corrected transposition is heart block. And that is the clue given by the pacemaker here. So think of the pacemaker, complete heart block in a child Usually, most common condition is either idiopathic complete heart block or congenitally corrected transposition. And then look at the left upper convex border. It more or less firmly establishes the diagnosis of congenitally corrected transposition. Okay. Okay. I'm going to give you 30 seconds to interpret this X-ray. Any thoughts on that? Sorry. Yes. Can you see my X-ray here? Okay. Yes. Anybody? Okay. This X-ray. Sorry. I'll come back to that again. So what you see here is a large heart with the vessels apparently big in the hilum. Now, the hilar vessels are unusually big, very dilated RPA and LPA, but you don't see correspondingly any dilatation of the main pulmonary artery here. It's a concave pulmonary artery segment. Therefore, it doesn't suggest increased pulmonary vasculature. You don't see any end-on vessels or increased pulmonary vasculature in the periphery. Now, one possibility is, of course, this could be severe pulmonary arterial hypertension with pruning. But again, that should cause an increase in pulmonary artery size here. So that large pulmonary arteries with a concave pulmonary artery segment, somebody has said already, Sakshi has already said that, is a typical case of tetralogy with absent pulmonary valve causing, and Akshata is also right, with pulmonary incompetence. So this is an absent pulmonary valve causing a combination of pulmonary stenosis and pulmonary incompetence. Now, Akshara says concave pulmonary arteries and pruning. Yes, you could think of pruning in a case of, say, a single ventricle or a pulmonary transposition in which you do not have the pulmonary arteries forming the cardiac border. So, come back to my initial point. If you have a patient who is very mildly silent, if you have a to and fro murmur at the upper left sternal border, suggesting severe pulmonary incompetence, and if you have this X-ray, the diagnosis is absent pulmonary valve syndrome and nothing else. Therefore, a lot depends on the clinical finding and how you correlate with the rest of the finding on X-ray. Okay? Right. This X-ray I am going to explain to you what it shows. It shows what happens in its place of coarctation. Coarctation, you get a typical contour on the left cardiac border. If you look at the image of the anatomy, you get one bulge on the upper border due to the dilated pre-coarc segment here, and then you get a concavity due to the coarc itself, and then you get a bulge due to the dilatation of the post-coarc segment, what is called a 3 sign here. And you can see how the 3 sign is produced in the chest X-ray by the anatomy of the coarctation. Okay. Right? And this shows how the 3 sign is produced. Right? Can you see that? The 3 sign and the indentation of the aorta. Now, this requires some attention. If you do not pay attention to the aortic outline, this X-ray may be passed off as normal. And particularly in a child, when rib notching is often not prominent, it may be passed off as normal. Of course, if you have a physical sign of weak femorals or absent femorals, your eye should automatically go to the outline of the aorta. You can see this indentation, which is diagnostic of coarctation, the 3 signs. Now, the same thing on the medial side will be manifest as a reverse 3 sign or a E sign. But of course, you don't see the E sign unless you outline that portion of the aorta with barium. Therefore, what you get is a reverse 3 sign in barium-filled esophagus and a 3 sign in a plain axial chest. That's a very useful sign provided you look for it. All of you are familiar with what happens in a compensated case of coarctation. Numerous collaterals form, and one of the main sources of collateral from the supra-coarctation segment are the upper intercostals, which become very dilated and tortuous. They communicate with the lower intercostals, which feed back into the descending aorta. Therefore, the blood actually flows through the subclavian artery into the upper intercostal, communicate with the lower intercostals, and then flow back into the descending aorta. Blood flow occurs away from the aorta in the upper intercostal and towards the aorta in the lower intercostal. So you can see how these dilated intercostals actually indent the lower border of the rib. Therefore, the most prominent indentations occur in the upper ribs, in the chest, and you can see that the lower border of the rib are very irregular and indented. All these arrows outline the irregular border of the lower rib, and they are most marked in the 4th, 5th, and 6th intercostal spaces. You do not see much indentation in the lower rib as well as the first and the second rib. So most of the collaterals form the subclavian in the 3rd and 4th center space onwards. Okay, so this is a classical example of rib notching in the case of coarctation. Mind you, this rib notching takes time to develop, and therefore do not expect it in a child, and often they are easily seen only in children of more than 6 to 8 years old. So you can have very tight quark, you can have collaterals without rib notching in children younger than the age group. This is an example of a coarctation again. Can you see the rib notching here? Beautifully seen here. Rib notching seen in the upper rib, that is 3rd and 4th and 5th rib. Along with that, you see a beautiful notch in the outline of the aorta. Okay? So, typical coarctation. Yes, I'm waiting for your opinion on this X-ray. I think I have another 5 minutes to go. Yes, you got to be fast now. You can answer the more number of slides you can see, it's better for you. Akshada, somebody says technology is absent for Epstein. Well, I don't want diagnosis. I want you to describe the X-ray. 2 people have said Epstein, 1 person has said massive cardiomegaly. Yes, massive cardiomegaly is agreed. But please describe the X-ray. Take some points from what I have been talking in the last 45 minutes. Please describe the X-ray. Okay, I'm going to take over here. I'm getting, yes, somebody said right atrial enlargement, somebody said left ventricular hypertrophy and right atrial enlargement. Well, Akshada keeps saying Epstein's again and again. Well, it may be Epstein's, I don't deny that, but you're not describing it. Sakshi says RBOT is enlarged. I'm afraid I don't agree with that. In fact, the RBOT is not enlarged, it's concave. Enlarged means it would be straightened up and it would even bulge outside the excellent. Okay, let me take over. Yes, everybody says cardiomegaly, that's very clear. Cardiothoracic ratio approaching 75%, there is no doubt about it. It's not left ventricular enlargement, it's a typical rounded apex lifted off from the diaphragm. If at all anything is there, it's actually right ventricular enlargement. The right ventricular outflow is actually concave, it's not prominent. The main pulmonary artery is not prominent. The pulmonary vasculature is possibly normal because the middle segment, middle area of the lung and the periphery do not have any particularly great vessels. You do not have any end-on vessels on either side. So the pulmonary vasculature could actually be called normal or even reduced because the periphery appears relatively clear. The most striking feature is massive enlargement of the right atrium. You can see that it extends more than 5 interspace in the vertical direction. It probably extends halfway into the right chest, definitely more than 10 centimeters from the midline. So huge RA enlargement. RV and RA enlargement. It could be any condition which causes right-sided enlargement, severe tricuspid incompetence. Dysplastic tricuspid valve causes severe tricuspid regurgitation. But the shape of the RA is a very typically a box shape. You can see that square shape, the square shape of the right atrium, which is supposed to be very classical of Epstein's anomaly. It's not diagnostic, strongly suggestive of Epstein's anomaly. So the classical findings of an Epstein's chest X-ray are cardiomegaly, particularly enlargement of the right atrium, a square box-shaped appearance of the right atrium. Along with that, a particularly non-prominent right ventricular outflow tract or even concave right ventricular outflow tract, and lungs which are normal are oligemic, relatively oligemic. This right atrium enlarges that indicates that there is tricuspid incompetence, and the relatively reduced pulmonary vascular indicates probably a reduced forward cardiac output, and possibly this blood is going through the intra-atrial communication to the left side, causing some degree of cyanosis. This is a classical X-ray of a Epstein's anomaly, but it doesn't rule out really other causes of severe tricuspid incompetence. This is also another patient of right atrium enlargement, but to a lesser degree. But note that the typical square shape of the right atrium, which is almost diagnostic of Epstein's anomaly. Right. Quick comments on that X-ray. We've got to wind up in a few minutes. Yes, any takers? So this is also a massive cardiomegaly like the last one. Right ventricle is enlarged, RA is enlarged. Sakshi says, right. Somebody said some money bag, or what bag appearance did you say? Somebody said some bag, okay, I'm looking. Massive cardiomegaly and pericardial effusion. Another answer from Akshata, massive cardiomegaly and massive right atrial enlargement. Yes, right atrial enlargement is there, massive cardiomegaly is there. But it's not the same as the previous one. You got to make some differentiation. Previous one also said you said cardiomegaly and right atrial enlargement. What is different here? What is different here is the left heart contour. You see, this contour is merging into the diaphragm. It's going down and out. It's not the typical right ventricular contour. It's merging into the diaphragm. Yes, actually you are right. The significant pulmonary venous hypertension, you can see the upper lobe vessels are very, very prominent. The vessels are actually prominent. Can you see the hilar arteries here? The vessels can be traced into the periphery. Okay, a huge cardiomegaly. There is a huge enlargement of the cardiac cylinder. Yes, right atrium is enlarged, but it's more suggestive of left ventricular enlargement. Can you see the dipping it down and merging the diaphragm, touching the left chest wall? And can you see the bronchus as it's played out? Can you see faintly the left bronchus here? Bronchus has been played out. I can't see a clear double density, but I think the bronchus is clearly splayed out. See the left ventricular configuration, the splayed out bronchus, pulmonary venous hypertension, massive cardiomegaly. All heart chambers are enlarged. Left ventricle is enlarged, LA is enlarged, right atrium is enlarged, and by default, the left ventricle must be enlarged. The right ventricular outflow is enlarged. Can you see that bulge here? Severe pulmonary venous hypertension. Haziness present in the hilum. Haziness present in the hilum. Therefore, this is obviously a PAM cardiac enlargement. All chambers enlarged by pulmonary venous hypertension. The consistent is multivalvular heart disease. The MR, AR, MR, TR, MR, PH, TR. You don't know what it is. One thing I'm sure is that this is not pericardial effusion. There could be pericardial effusion, but this is not primarily pericardial effusion. But the cardiac contours are still preserved. You can see the SVC here, and I can see clearly the angle between the SVC and the RA. I can see little changes in the configuration in the left cardiac border. This is not the appearance of pericardial effusion. Pericardial effusion is a money bag or leather bag appearance, not money bag, sorry, I'm sorry, leather bottle, leather bag appearance. You get a smooth line right from the superior mediastinum going into this. You do not get these curvatures in the cardiac contour. You get one big sac right from the superior mediastinum up to the diaphragm. So this is right atrium and left atrium put together. This is not pericardial effusion. So this is massive cardiomegaly, cardiac failure, typically multi-chamber enlargement of cardiomyopathy, multivalvular heart disease, any of those conditions. Okay? Right. Yes. Quick diagnosis. This is the neonate. Another huge, massive cardiomegaly. Differential diagnosis. Quick. We're running out of time. Obliteration of cardiac cell, says somebody, Akshada. No, Akshada is hydrox. Hydrox is a fetal condition. We don't diagnose hydrox. Somebody says obstructed TA-PVC. No. Obstructed TA-PVC doesn't cause cardiomegaly. Obstructed TA-PVC, the shunt is smaller. Therefore, the cardiac cell is often small and the lungs are edematous. That is obstructed TA-PVC. This is massive cardiac enlargement. Again, the right atrium is touching the right chest, and the left side of the heart is touching the left chest. So, cardiac thoracic ratio is 100%. Therefore, massive cardiomegaly, you have to talk of differential diagnosis. One diagnosis, neonatal Epstein. Sakshi, you are right. Neonatal Epstein, huge, massive RA enlargement. Neonatal Epstein. The other differential diagnosis can be massive RA enlargement due to pulmonary atresia with intact ventricular septum. That also causes torrential TR and giant RA enlargement. When you see a neonate with this chest X-ray, and you can see that it's a very sick patient because you can see endotracheal tube here, you can see chest lead from the chest. A neonate with this X-ray, think of neonatal Epstein with heart failure, because neonatal Epstein causes very, very large TR and very sick child because the pulmonary vascular resistance is high and the tricuspid valve leaks due to. Yes, actually, you're right. Severe tricuspid incompetence due to severe TR due to any cause in the neonate. Most commonly, either neonatal Epstein or it is pulmonary atresia with intact ventricular septum, or occasionally due to just idiopathic dysplastic tricuspid valve. Occasionally, you can even say idiopathic PAH of the newborn, but I would more in favor of idiopathic RA dilatation not idiopathic, sorry, Epstein's with RA dilatation or pulmonary atresia with intact ventricular septum. Okay, now that applies only to the neonate. Okay, but if you know the neonate, those are the two diagnoses. Okay, possibly the last slide now. Yes. Quick answers and we are winding up after that. Let's start with the X-ray on the top left here. This one at 10 o'clock position. Start with that X-ray. That is simple. Why do you say severe TR due to any cause? I'm talking of first X-ray on the left side. That's not severe TR. Somebody said tricuspid atresia. Akshara says RV apex concave pulmonary artery segment. Very good. Yes. That's exactly what he says. This is a typical boot-shaped heart of. I'm sorry. This is a typical boot-shaped heart of tetralogy of Fallot. Let's see a round lifted up apex, right ventricular enlargement. You see a concave pulmonary artery segment. Now that's what causes a boot-shaped heart. A RV apex, rounded RV apex, a concave pulmonary artery segment. That, along with oligemic lung field, gives you the picture of tetralogy of Fallot. Now this is a typical tetralogy of Fallot. Of course, this doesn't rule out tricuspid atresia. In a typical patient, typical cardiac finding, this X-ray is diagnostic of tetralogy of Fallot. But if you have mild or more moderate RA enlargement with a box-shaped RA, and along with that a prominent SPC here as shown here. This X-ray I'm not paying too much attention to that because it's slightly rotated X-ray. If you are convinced that the SPC and RA are more prominent, you could think of tricuspid atresia. Somebody said here, Dr. Sandeep is telling that here. So think of tetralogy when you see a boot-shaped heart along with oligemic lungs. Now in some cases, in tetralogy of Fallot, the thymus may be large and therefore the superior mediastinum may not be typical. Okay? Look at this X-ray. You have a right ventricular type of contour, a concave pulmonary artery segment, and oligemic lung. But the superior mediastinum is causing trouble here. It is suggesting something like a wide superior mediastinum. Now think of other causes. It may still be tetralogy of Fallot because of the other findings, and this box-shaped appearance could be a large thymus. It could be a thymus, so everything else fits in the diagnosis of tetralogy of Fallot. Now this X-ray is taken from an adult tetralogy of Fallot. What does it show? Anybody wants to comment? RV apex pulmonary artery segment. Yes. What else does it show? Akshara says RV apex and concave pulmonary artery segment. Very good. Who said that? Aortic dilatation. Somebody said aortic dilatation. Mirza. So that's Sakshi also. You are right. A dilated aorta is a very typical feature of any tetralogy of Fallot, and this dilatation keeps on increasing as they become adults. You can see that this is an adult patient, and although it has features of tetralogy of Fallot, the ascending aorta is hugely dilated. Very suggestive of an aneurysm of the ascending aorta. Along with that, the heart size is also increased. Now, why should the heart size be increased? Typically, tetralogy of Fallot, the heart size is normal. When you have a tetralogy X-ray with massively dilated aorta, you think of AR. So I'm showing you two common complications of adult tetralogy of Fallot. One is a dilated aorta, which may itself be one complication. It may cause secondary aortic incompetence, leading to massive cardiac enlargement and heart failure. So think of adult tetralogy when you have abnormal findings and complications. So ascending aorta dilatation, ascending aorta aneurysm, aortic incompetence, left ventricular enlargement, left ventricular dysfunction, right ventricular dysfunction, cardiac arrhythmias. These are the common complications of adult tetralogy of Fallot. Therefore, this X-ray is a typical example of complicated adult tetralogy of Fallot. Okay, I think we are running out of time here. Thank you for your attention. I hope this X-ray session was useful. I'll be putting up a few quiz questions in NB session. Please look out for them and try to answer them. Thank you and bye-bye.